Uh, my name is Sam El-Dabi. I'm consultant anaesthetist at James Cook University Hospital in Middlesbrough in the UK. And welcome to this webinar where our central question would be about the value of trials in spinal cord stimulation and the issue of whether to trial or not to trial. We will explore the diagnostic utility of screening trials, the patient benefits, the cost effectiveness, and above all, what are the patient's thoughts on trialing. We will be presenting the results of the trial STIM study. Trial STIM study is a collaboration between 3 NHS organizations and 5 academic institutions. And the study was funded by the National Institute of Health Research through the RFPB program, and the devices were paid for by the UK National Health Service. Those are the disclosures of your speakers for tonight, and I'll leave them there for a minute so you can have a look at them. But as far as this study is concerned, none of these disclosures were relevant because we were looking at spinal cord stimulation as a generic intervention, not a device-specific intervention. Now, before I go on to introduce you to your speakers tonight, I will ask you to use the Q&A button to post your questions, please. After the end of the talk of each speaker, I will pose 1 or 2 of your questions to them, depending on the timing. If that does not answer your question, we should have enough time at the end of the webinar to answer most questions. This is our lineup. Dr. Thompson will start us with the background, then Dr. Barani will talk about the methods used in the trial STIM study. Dr. Gulve will then go through the patient outcome measure results. Professor Taylor will go through the diagnostic results of the trial, of screening trial as a test. Then Dr. Ruedwart will talk about the nested health economic analysis. Dr. Raymond Chadwick will talk about the qualitative analysis, and I'll come back to talk to you about the conclusions of the study. So if I may now, I will hand you over to Dr. Thompson, who will talk to you about the background in screening trials in spinal cord stimulation. Simon, can you share? Thank you.
Unmute. Well, good evening, everybody, if you're talking from this time zone. I'm going to talk about the history of spinal cord stimulator trial period. So when I think of spinal cord stimulation and trying to get really good outcomes, I'm thinking there are 4 pillars for successful outcome. Over on the left is, I think, probably the most important is patient selection. Most of us, and in fact the 3 centers that are involved in this study utilize a multi-professional team. And some work I've also been working on is on trying to make that drill down onto that to patient level selection, and that link there takes you to a different piece of work, which is we know as the E-tool. We talk of centers of excellence, high volume centers where there is a high degree of quality in the actual implant techniques. I think, as we all know, you get that wrong, you can ruin an outcome. And I think we have to have a organized service so that we can do good follow-up arrangements and reprogramming in a timely fashion. And then we're all interested in some of the new technologies that are coming along that supposedly should be making our lives easier. I'm just struggling to advance, okay. So just to recap, we have patient selection, high quality implant takes, good good follow-up arrangements and programming, advanced technology. But when we think about selection, we should be looking at what is the clinical appropriateness of treating that patient with spinal cord stimulation. And we think about the biomedical characteristics, we think about the psychosocial characteristics, and then the last thing has been this tradition of let's do a trial, and if that's successful, then we treat them with spinal cord stimulation. So where did this all come from? Well, spinal cord stimulation, as you probably know, used to be more of an open technique, using large contacts in a wide-spaced arrays of electrodes. And so getting a treatment responder was difficult in those days. And there was a rudimentary knowledge base about the appropriateness of spinal cord stimulation and what cases that would treat. In fact, the percutaneous technique was developed in order to provide an ability to trial the procedure before the neurosurgical implant. And really, we've seen this evolution where through the needle techniques are becoming the preferred technique over and above an open laminotomy. I think cost containment has always been and still is this concept that a trial, if you only implant successes, then you're going to save money. And then in order to try and persuade patients to, if you like, consider spinal cord stimulation, there was this concept of trying before you buy it. And then I think as far as the evidence base is concerned, all the trials that we rely on to make the case for spinal cord stimulation reimbursement have all got a trial period within them. And so bodies such as NICE, it's a no-brainer to them. If the evidence is used trials, therefore you should use a trial. But I think as we go through some of the randomized controlled studies, you'll see that there are major differences in how this is reported. And I just always draw your attention to PICO, which is a mnemonic to try and help you understand studies. Think about the population, what's the intervention, what's the comparator group, and what are the outcomes that are being used. So some of this is in failed back surgery syndrome, famous studies. There's the Rick North study on back and leg pain, and this was a crossover design. And in the group that started out with spinal cord stimulation, 19 out of 24 had a successful trial, which was judged by 50% percentage pain relief and medication and physical activity improvement. And then those patients who were allowed to cross over back from surgery back to spinal cord stimulation, all 14 of them had a successful trial, giving a perm to trial ratio of 87%. At 2 years, the story is slightly different. And there is a theme that you'll notice here. Of those 19 patients who started out in the SCS arm, only 47% of them maintained a responder rate of 50% pain relief. And if you just look at the intention to treat in that group, it's as low as 37.5%. When we go to the Kumar study, the perm to trial ratio was 82.7. But interesting, when you read closely, 5 out of the 9 failures were actually wanted to have the implant and were actually included and in the study and implanted. So you could argue that there was a 92.3% perm to trial ratio. But as we know, at follow-up, at 6 months, only 48% on the intention to treat maintain that level of pain relief. But obviously, if you excluded the 5 trial failures, it just goes up to 51%. Then we had the unblinded Senza study, and in both groups, you had high rates of perm to trial ratio. When they published their 2-year data, remember, this is only looking at the implanted patients. It wasn't looking at the intention to treat. And they found 76.5% in the 10K and 49.3% in the paresthesia-based arms maintained a greater than 50% pain relief. In a non-commercial study that looked at something similar to the Senza study, again, we found high rates of perm to trial ratio, 90% or more. Professor De Andres did not publish responder rates, although they used a 50% reduction of NRSPI from baseline for their analysis of the trial. But at 1 year follow-up, unfortunately, they didn't continue with the responder rates. We've just got a modest reduction in pain scores, whether it be in the 10K or the paresthesia group. In my own study, which was the PROCO study, and what's interesting about this, as you know, it's a double-blind study for the 4-way comparison bit, but what was interesting was we recruited patients by using a paresthesia-based paradigm, and then we went and did a second trial using 10 kilohertz, and we tried to recruit 21 of those patients. So the interesting thing was that we had a 97% perm to trial ratio using our usual care, which happened to be paresthesia and measuring it in a verbal report of pain relief. But when we used our e-diary, we found that only 68% of those would respond to a 10K trial. But we then went on to show that when they were randomized, that there was a 50% responder rate across all those frequencies as before. So then we have the Sunburst study, which actually is an enrichment study. The patients were trialed before randomization. So they only really looked at the 112 because 11 had exited the study. So they were left with 101 patients who had had a successful trial. And they only then published looking at those 100 patients who had been randomized with a 30% responder rate at 24 weeks and showed an intention to treat being modest at 69% across both groups, or 60% for burst and 51% for paresthesia based. So often when you look at all of these studies, you're comparing apples with pears. So it's very difficult to get the information. More recently, we had Rigaud's study, which had a perm to trial ratio of 80%. Their usual practice, and they left it up to the center, but again, a usual report of a percentage pain relief, verbal report. But when they looked at outcome, their responder rate was disastrously low, really, and with an intention to treat of 13.6, and of those that completed the study, 16.3%, and as treated 20%, achieving a 50% pain reduction. Then there's been a commercial study with Saluda, with the closed loop on and open, with very high rates of greater than 90% perm to trial ratio, and quite well maintained responder rate out at 3 months on an intention to treat, 82% with the closed and 60% open. So then if we turn to the real world and we look at large case series, this is in the US, and this tells us a little bit about US practice, I think, compared to my own case series, which is similar numbers of patients done in a different system. In the US, 67.8% perm to trial ratio. I was getting 91.6%. Despite that, despite the apparent more, if you could ask, conservative nature of proceeding, they ended up with a 13.7% explant rate due to poor pain relief, whereas we had a 3.4% explanted due to poor pain relief. That's less than 1% a year. So hopefully you're seeing that the evidence for a spinal cord stimulator trial is looking pretty thin as far as predicting long-term outcomes. The next thing, and you'll hear more about this from Rui, was we wanted to look at just the economic value of the acquisition costs. What does it cost to do in the UK, to do a trial period and then an implant, or to go straight to implant? And what would be the break-even cost? How many out of 100 would you have to implant before it becomes cost effective? So we looked at the perm to trial ratio and we asked that question, above which it increases acquisition cost to do a trial period. And Rui did upper and lower 95% case bounds. And we broadly presented this data as a base case for the cheaper version. Now, all the costs, as Rui will explain, are all held, are reference costs held by the NHS. So it's not a question of adding up the cost of a lead and an anchor. This has all been done for you. And for a non-rechargeable, your perm to trial ratio, if it's would have to be 67% for the base for it above which you're wasting money, and for the more expensive devices is 80% above which you would be rating money. And as you can see in my own field with 91%, we're essentially not showing presumably any value in doing a trial period, but we'll talk about that later. But then what about the other way around? What about patients who have had a trial period but have not responded? What's the fate of them? Well, we don't do many of those because we don't always implant them. But in this particular study, they were all implanted. And as you see over time, although I know there's a dropout in numbers going forward, but you can see that the group start to become responders over a longer period of time. So in other words, they might have been thought to have been negative, but actually they're positive. And so this brings us, and we're going to hear more about this from Rod Taylor on sensitivity and specificity, but I always find this very difficult to get my head around it. But obviously sensitivity is, we want to pick out true positives. That's a good thing. We don't really want to have people registering as positive who are not. That's a bad thing. And then similarly, specificity, what we want is to have, to be able to identify true negatives, but we don't want to be fooled and have a false negative. So ideally you have two tests, and the first you want to have high sensitivity, so we select all the positives, and the second has to have high specificity, so we can exclude all the negatives. But I don't think we have that from a trial period. Now, the other problem is apples and pears is looking at the types of trial, and there's marked variation. Now, I know there are going to be exceptions, okay? And I know, so I don't want to cause any arguments, but essentially in Europe and the rest of the world, trials tend to be performed by the implanter. And the eligibility for spinal cord stimulation is implicit before the trial period starts. In other words, you would be able to get the funding. You don't have to ask permission to do it if they've had a successful trial. In the USA, it's quite different. The trials are often done by a referrer. So this incentivizes a referrer. But the quality of how that trial is done is highly variable. And in fact, some implant centers repeat the trial again. So, and the decision on eligibility when they're negotiating with insurance companies is often after the SCS trial. So they can provide the result of the SCS trial. And sometimes they'll still be turned away. The other thing which is quite different is the relationship between the industry representative and the implant center. And often these trials are monitored by an industry representative. So there are conflicts of interest. I think the other thing is that we've tended to, well, my center, I know Sam's center, and some European, we tend to do this staged trial. We use the definitive lead with a extension and internal anchoring. Whereas in the States, it's almost universally a percutaneous trial and the lead is then discarded. So that works both ways. There's more skin in the game. A patient has had a proper operation. They've been cut open. And so, yes, of course, you could argue they're more likely to say, yes, I've got this far. I'm going to have my complete trial, complete treatment. And so that works both ways as well. Now, the other thing is that what about trials now? We live in an era of multiple waveforms. So there are those that advocate anatomical placement. And the assumption is that if the lead is placed in the midline at some point in the spine, that the programmer is the one who actually does the e-trial, the electronic trial. And the advocates of anatomical pacing are now in a right mess, because now they're advocating using paresthesia-based stimulation. But of course, the position, unless they've even done an on-table trial, is likely to be suboptimal. I think my other concern about anatomical placement is that it's being encouraged people to have these things under general anesthesia, which of course aerosol generating procedure nowadays, and increases risk. And the other thing is anatomical placement prolongs the trial phase, because there are many more programs to run through with slow wash-in and so on. So there's a targeted stimulation placement. That does require patient cooperation. I mean, I tend to use very light sedation whilst I'm talking to the patient, and lots of local anesthesia. Other people will use deeper sedation and lighten it at the crucial moment. Are we going to trial with paresthesia or subperception? Are the targets the same? Can you do an on-table NRS assessment with subperception? You can often, with a prolonged paresthesia, get an idea as to whether it's helping pain. And then most of us use a verbal percentage pain relief score. And is that how valid is that? It always over-exaggerates, as I think we can see. We always expect 50%, but then, you know, that's what we define as our responder rate. But I think in reality, we know that something lower is what's important to patients. So then what about the idea of doing an on-table trial compared to a prolonged trial? And this is a piece of work done from Arizona, and they used 50% pain relief guide to implantation. And then they looked at their longer term follow-ups at 9.4 months. And they found that of those patients with greater than 50% pain relief, during the screening process, so this was like 15 minutes on the table, 53 out of 54 responded. And then at 4 or 5 days post-op, there were 47 out of 52 responding. They lost a whole lot to follow-up, so it's rather difficult to make a lot of sense in. But the concept is that perhaps even just a 15-minute trial is just as good as a longer-term trial, if we believe in trials at all. And then the last thing I'd like to talk about is a trial period benign? Recently we had Rigouard's study, and Rick North did a sub-analysis of this, just looking at infection rates that became apparent either during the trial or at completion of the trial. And they had a high rate of infection of 5.2%. But what they found is that there was a cutoff point. If they let the trial go on for more than 10 days, then almost a quarter of them would end up with an infection. Well, in some institutions like health economies like Belgium, it's mandatory to do a 3-week trial. And in fact, in Belgium, they had a 21.7% infection rate. So they actually had to pause the trial and take remedial action. And they got special permission to shorten the trial in Belgium. People were using surgical open leads with extensions. And this, of course, had an unacceptable trial infection rate as well, 6.8% compared to percutaneous of 1.8. In some very good work on diabetes and RCT by Rachel Schlangen and her group, they had a very 77% perm to trial ratio and a good outcome responder rate at follow-up at 59% compared to usual care at 7%. But they did have a death, and this was following a dural puncture during a trial period, and the lead had been withdrawn. And then some recent HF10 work, Amir Delfan, in the neck. They had 2 major complications. One was an extradural hematoma and one was a device infection. But I think we all know that there are multiple anecdotal reports, some of which we just chat about rather than actually get published. And then I think in an era of COVID-19 with footfall into hospitals, are we just doubling needlessly the visits to hospital? So what is a trial, is this the right role of a trial period of SCS? So I don't believe that a trial is a substitute for doing patient selection properly. The sensitivity is good, but the specificity is poor. I think a trial period can be on table or it can be prolonged. I think going beyond 10 days is increasing unacceptably the possible rates of infection. And there is risk of neurological harm if you're insisting on doing multiple epidural accesses. Some people might say you can measure current requirements and so decide whether you want to put in a non or rechargeable device. And you could argue that can a patient tolerate SCS? Well, I think there are so many sub-perception programs now, I don't think one can really think that that's useful. So I think that there's very little evidence at all that a prolonged SCS trial predicts long-term outcome. Other factors in patient selection, to my mind, are much more important and require much more care and attention and, if necessary, investment. There is a lack of quality standards for SCS trials. Trial periods have an underestimated risk of complications. The poor cost effectiveness of trial periods suggests that resources should be redirected, and I mean that into improving SCS selection. And I remind you of just as our work showing the perm to trial ratio. If you are exceeding, then you're wasting money. So with that, I'm going to hand over to Barani.
Well, thank you very much, Simon. That was a very thought-provoking review of the evidence of trials. I'm sure there'll be lots of questions for you towards the end. So Barani will now take us into the methods of the trial STIM study. It's with you, Barani. We can't hear you, so if I may unmute you.
Oh, right, sorry, Sam. I was just sticking to the boss's commands and kept myself muted. For the participants, if you have any questions, please do type as we go, because then we would be able to collate them and get back to you. So in the next 10 minutes or so, I'm going to be talking about the methods of the trial STIM study. So the hypothesis is no screening trial strategy, in essence going directly for a full implant, will be clinically superior and more cost effective than doing a trial followed by the full implantation. So our aims as a clinician, I would like to have compare the patient-related outcomes of doing a trial versus directly going for a full implant. We need to determine the diagnostic performance of the trial, especially looking at the sensitivity and specificity of doing an SCS screening trial. As a payer, is this cost effective? So for example, the NHS is paying for this treatment. Is this, compare the cost effectiveness of a trial followed by full implantation versus directly going for a full implantation. And if I was a patient, what would I like? My expectations and experiences of going through a trial phase and then implantation, or directly getting into a full implantation. So this is a superiority parallel group, 3-center randomized controlled trial with a nested qualitative analysis and economical evaluation study. The patients were randomized on a one-on-one basis to either a trial followed by full implantation, or directly to a full implantation, which is no trial implant only. The outcomes were assessed at baseline, 3 months, and at 6 months. And this was between 3 centers in the UK, and I think we chose three centers because of the volume of implants being performed. And these were Middlesbrough, Leeds, and Basildon. We sought after to recruit about 100 patients who are going through SCS based on the NICE TA 159. So inclusion criteria is very straightforward because these are patients who are all being assessed by your unit as per the NICE TA 159 and are on the waiting list to have your treatment. So for people outside UK, the NICE TA 159 suggests strict criteria of selecting patients. And I think this is purely a neuropathic or pain score of more than 5 or equivalent on an NRS. And this should be persistent for more than 6 months, and all other conventional medical management must have failed. They should have a satisfactory multidisciplinary assessment, and this could vary from unit to unit, but a multidisciplinary assessment is an essential, and the patient should be able to provide an informed consent. Exclusion criteria, if they did not want to take part, obviously. And then if there is any other ongoing pain condition which we think will overshadow the neuropathic pain, then those patients were not recruited. And in fairness, those patients don't get the SCS implant at present in the UK. So for example, if a patient is on a high dose opioids, those things are worked up even before we place them on an SCS waiting list. If they had a previous treatment with implanted device, then they are not allowed to come into the study. And if they're taking part in other studies and has a contraindication with anticoagulation therapy, because obviously we still implant patients who are on anticoagulation therapy with strict rules of going directly to implant and so on forth in a very selected groups of patients, but we couldn't really recruit them into the study because if they fall into the trial arm, they would not be able to have the trial. If there's any poor cognitive ability or lack of capacity, pregnancy or planning for pregnancy, which are all routine exclusion criteria. We identified these patients in the outpatients, and there was no stipulation on whether you did a perm trial or a temporary trial. So I call it perm trial is when you anchor the electrodes and have an extension, or a temporary trial where you just place the electrodes and then take the electrodes out at the end of the trial period and then put them on for implantation. A successful trial, if they went through the trial phase, is more than 50% reduction in pain and or more than equal of 80% coverage in paresthesia. We also looked at various other things such as reduction in analgesia and improvement in activities of daily living. On the other hand, the key issue is when the patients directly went in for a full implantation without a trial. If we're doing a paresthesia-based system, we wanted to get at least 80% plus of the painful area with the paresthesia cover, and the patient goes, I really like it. And sometimes they also come out with a positive effect of saying, yes, my pain is feeling better already. If it is an anatomically placed system such as HF10 or burst, then we would make sure that the electrodes are anatomically in an ideal place and acceptable, then the full implantation is carried out. The primary outcome was the NRS scale at 6 months compared to the baseline. We also looked at NRS scale over a 4-day diary. We then segregated the patients to more than 50% reduction in pain and more than 30% reduction in pain based on the NRS scales. The quality of life questionnaire using the EQ5D, sorry, health-related quality of life using EQ5D, the disability questionnaire using Oswestry Disability Index, patient satisfaction on a global impression of change, the complication rates, and the healthcare utilization during the trial period. For example, if there's any GP visits and so on forth were captured. To minimize the bias, the patients were only randomized on a password-protected web-based system developed by the Exeter Clinical Trials Unit. The allocation was revealed to the site manager only after a return informed consent and baseline outcomes were entered into the system, and they were all blinded. I'm not going to go too much into the data analysis because that's something that would be covered in the following slides. The qualitative study was done as a telephone interview, which is a standard structured interview, and with selected patients from all 3 trial sites. They were interviewed post-randomization, but the patients were not aware of which arm they belonged to. So they had a pre-implantation interview followed by a completion, after the completion of 1 month, a post-implantation questionnaire. And they were asked about various expectations and preferences, which Raymond will cover later on in the talk. With this, I pass on the slides to Dr. Gulwe, who will give you the results of the study. Ash?
Thank you. Let's see if we can get started. Can everybody see me and hear me? So the thing that we are waiting for the all evening and for so many months, the results of trial STEM study. So I'll walk you through the study consort diagram. We had about 137 patients that were randomized to that were assessed for eligibility for participation in the study. About 30 patients were excluded. Majority of them, 27, declined to participate in the study. 3 had other reasons, out of which 2 were actually duplicated enrollment in error. So we had randomized 105 patients, with 54 patients allocated to trial group and 51 patients allocated to non-trial group. Out of those who were allocated to non-trial group, 2 patients withdrew before their implant. And at 3 months, there were 48 patients who completed their 3-month and 6-month follow-ups. In a trial group, we had 54 patients who were allocated, out of which 47 had the allocated intervention. 7 patients withdrew before their trial implant. 3 had personal reasons, 3 had worsening comorbidities, and we lost contact with 1 person. Those who underwent trial, 5 patients failed the trial. We've tried to follow these patients up. It is very difficult for patients to keep engaged when they know they have failed the trial and they're not getting the intervention. So out of 5, 3 patients withdrew and 2 missed 3-month appointment. At 6-month appointment, we had only 2 patients who had failed the trial, but who continued with their follow-up appointments. And Professor Rod Taylor will explain the consequences of this in terms of the specificity and sensitivity of the trial. 42 patients had successful trial and 39 completed 6-month follow-up appointment. 1 patient withdrew before 6-month appointment, and 3 patients missed 3-month follow-up, while 2 discontinued because of the serious adverse events or adverse events. When you look at the demographics of these patients, their baseline characteristics were quite comparable amongst both the groups. Their numerical rating scales were comparable. Their pain levels were comparable in both groups. They were quite disabled, and they had poor quality of life as reflected on the EQ-5D. What was the indication for spinal cord stimulator? When we look at the whole cohort of 105 patients, as expected, majority of the patients, 44%, were patients with failed back surgery. About 16% patients were radiculopathy. Some of these would have never had surgery. 17% were chronic post-surgical pain, which is again neuropathic pain of other origins. And then there are CRPS 1, 2, and all other indications. There are 7% patients here who had low back pain. When you look at the comparison of patients in trial group versus no trial group, again, we had similar distribution where majority of the patients were patients with failed back surgery. As I said, their baseline characteristics were comparable numerical rating scales. So the pain severity, the extent of disability was quite comparable among both groups. Their quality of life was quite poor and comparable in both groups. This was the medication list that these patients were taking, and also the duration of pain. We know certainly in the UK, these patients wait for a long time. And we had average waiting time of 108 months in a trial group and 128 months in a no trial group patients. So on an average between both groups, we had 117 months of average pain duration. As expected, majority of these patients were on combination of simple analgesics, antidepressants, anticonvulsants, opioids, and non-steroidals. Some of them were on additional medications such as muscle relaxant sedatives. Some were using transdermal local anesthetics. Some were on oral steroids for other indications not related to pain. And there are some other medications that may have effect. When it comes to their work status, again, there were a majority of the patients who were not working because of the pain in both groups. What about devices and programming? So which system we will use was left to the center practice and the center allocation for that particular patient. There was no stipulation in the trial of using a particular device for a particular indication. We implanted devices from the 4 major manufacturers. Devices were generally programmed by neuromodulation nurses at each centers with industry and a PI input, principal investigator input, if required. Among the programming parameters across the study, we had 32 patients who had paresthesia-based stimulation, 36 patients who had 10 kilohertz high-frequency stimulation, and 22 patients were on burst stimulation. Some patients did receive more than one program during the study. So as a part of this study, which was an open, normal, usual practice of each center in various corners of the country, we had 42 out of 47 successful trials, giving overall trial success rate of 89%. The mean duration of trial was 9 days, just over 9 days. The median was 7 days, and the range was anywhere between 5 to 22 days. Simon touched on 2 types of trials: temporary trial, which is percutaneous or non-anchored trial, or a definitive trial, which we call permanent trial, a tunnel trial. There are various names. About 33% patients had definitive trial, and 14 patients had temporary trial. Again, the type of trials was left to each individual center's practice, usual practice. So what are the outcomes? So a baseline numerical rating scale in both arms was about 7.5. At 6-month follow-up in a trial group, the pain level dropped down to 4.3 out of 10. And in a no trial group, it was 4.5 out of 10. So there was no statistically significant difference in the numerical rating scale of pain between the 2 groups. When you look at EQ5D, in a trial group, the baseline EQ5D was about 0.32. At 6-month follow-up, it was 0.57. In the no trial group, again, very similar, 0.3 at baseline, 0.53 at 6-month follow-up. There wasn't any statistically significant difference in the quality of life between the 2 groups, though you can see that the quality of life had increased significantly compared to baseline in both groups. When it comes to the disability, again, we started with a reasonably high disability index in both groups. And in the trial group, it was reduced to 36, while in a no trial group, it was reduced to 41. And there is a mean difference of about 1.7. What about the secondary outcome measures? So a numerical rating scale maintained by a patient with a 4-day diary. Again, baseline was 7.3. At follow-up, it was about 4.1 in a trial group and 4.8 in a baseline group. About 37% patients in the trial group and 40% patients in the no trial group reported more than 50% pain relief, while 56% patients in the trial group and 58% patients in the no trial group reported more than 30% pain relief. In both arms of the study, patients' global impression of change, 97% patients in the trial group were satisfied or very satisfied, and 87% patients in the no trial group were again satisfied or very satisfied. What was the impact on pain medication? So we compared patients' pain medication at 6-month follow-up and compared that to baseline and at 3 months. As you can see from this table, most of the patients did continue their medication in both the groups. Only small proportion of patients stopped their medication, and in one patient in each group, the data was missing. What about serious adverse events? At 6-month follow-up, again, in the trial group, there were 2 explants due to infection, out of which 1 patient was reimplanted. Overall infection rate was about 2%. Other adverse events such as superficial wound infection, new neurological change, moderate to severe pain at implant site, and other non-device related problems were quite small. Overall, serious adverse events were comparable to what is published in the literature recently. And with this, I will hand it over to Rod.
Before we go to Rod, I think we have a question, an interesting question, if you don't mind, from Georgios Matis. He's asking, according to your experience, is it easy to convince patients to get the lead and the IPG in one operation without doing a traditional trial? I think this will be answered very clearly by Dr. Chadwick's talk, because he'll talk to us about the patient's views. But you ask another question about, is the age of the patient of importance? And if I remember correctly, Rod, we did an analysis of over 65 versus under 65, if you may care to comment before you start your talk.
Sure. So we did that analysis, and I think, correct me if I'm wrong, Sam, we didn't find any differential effect across those 2 groups. Is that
no, you're quite right, yes. So I don't think there was much difference between over 65 and under 65. So I hope that answers your questions, Georgios.
I guess the only caveat that I'd throw out.
Right,
is,
well, we're with you, Rod.
Okay, thanks, Sam. So I think the only caveat I would make to that previous remark is that the studies are relatively small one, and we weren't powered for subgroups. So we should bear that in mind. But anyway, thank you to Nsuke, and good evening, everybody. Thank you for the opportunity to present the diagnostic results, sensitivity and specificity. Next slide, please. Or do I move them down?
No, you can move your own, if you like.
Okay. Sorry, Sam. Just benefits of not joining the pre-meeting. How do I advance the slides?
Well, you're advancing them.
I think the control is with me. So Rod, let me see if I can give the control to you, or do you want me to advance those for you?
Well, if you're happy to advance them, that would be great, Ash. Thanks.
I'll do that. I'll do that.
Okay, so you've already seen this, which is the various aims of the study, but I'm just to reinforce again, I'm going to concentrate on the aim, next slide please, of looking at the diagnostic performance of the SCS screening trial. Next slide. So I've put this flow diagram up, and you'll notice it's empty, and you've already seen this from Ash. But the reason I wanted to put it here is that it's just to emphasize that we can only look at diagnostic performance, or remember this is a screening test rather than a diagnostic test, screening performance in the context of those individuals who got both a screen and also went on to have an implant strategy. So just to highlight that, next click please. Effectively, I'm going to be concentrating on this part of the consort flow diagram of the study. I'm not going to be talking about people who didn't have a screening strategy. Next slide. So the idea in terms of diagnostic or screening accuracy or performance is the following 2x2 table. So if you recall, those in the trial screening strategy will have a screen, And that screen can then be positive. In other words, they have more than 50% pain relief, or the screen can be negative. They have less than 50% pain relief, or whatever the criteria of success of the screen may be locally in a clinic. And then we follow those individuals up. And as you've heard, we've got 2 follow-up periods in this trial. We follow them up following spinal cord stim at 3 months and at 6 months. And according to the columns, for those individuals, we can look at their pain relief at 3 and 6 months and judge it to either be greater than 50% pain relief or less than 50% pain relief. And that allows us to then complete the cells of this 2x2. So in other words, if you have a positive screen and then you have an SCS implant and you go on to have pain relief, you're a true positive. In other words, the screen has identified you as having an increased likelihood of success. Similarly, if you have a negative screen and go on not to benefit from spinal cord stim, that would be a true negative, wouldn't it, or a TN? And therefore, the missing 2 cells, false positives and false negatives, are those individuals who have a positive test, but then have a poor pain outcome, or those who have a negative test and actually have a positive pain outcome, respectively. And we can use these cells to generate some statistics. Next click, please. So you'll just need to advance. Thank you. So the first statistic is the sensitivity, and the next one is specificity. So in brief, the sensitivity is the proportion of individuals who achieve pain relief with SCS who had a positive screen. So the idea, the way of thinking about this is that we generate the statistic using the left-hand column under pain relief. So it's the true positives divided by the number, the totals at the bottom, which is true positives and false negatives. Similarly, the specificity is the proportion of individuals who did not achieve pain relief with spinal cord stim who had a negative screen. And that, in contrast, is the number of true negatives divided by the total on the second column, which is false positives plus 2 true negatives. So you might just want to try and remember those statistics as we're going, but I'll come back and explain them later. So next slide. So cutting to the chase, this is now the completed flow diagram for our study that you've already seen. And again, if we click, make a click, one thing I just want to highlight is that, can you notice that in, first of all, the number of unsuccessful screening trials was 5, whilst in contrast, the number of successful screening trials was 42. But one of the issues, and I'll come back to this, is that of those 5, only 2 of those individuals had data at 6 months. In other words, we were able to follow them up. The other 3 individuals were lost to follow up. And clearly, not only is the number of people with unsuccessful screening trials small, but we've also got the issue of loss to follow up too. So next slide. So this is our, I guess, our main diagnostic sensitivity result, sensitivity and specificity result. And here we've completed the table. So as I said, we had 15 individuals who achieved pain relief at 6 months, as you heard earlier. 26 did not. And if we apply the appropriate formula, that means that we have a mean sensitivity of 100%, but do notice the confidence intervals are quite wide. It could be as low as 78. And a mean specificity of 8. And just to remind you, we obviously want both of those figures as to be high as possible. So far it looks as though we might have a sensitive test, but certainly one with suboptimal specificity. Now, remember I said that we lost some people to follow-up. So next click, thank you. What we've done here is in our publication, we undertook 2 scenario analyses. One is we imagined the 3 people who dropped out were a best case scenario. In other words, screen negative, and they didn't have pain relief. And under the best case scenario situation, can you see that sensitivity remains high, 100%, specificity doesn't change a whole lot. And then we could assume that those 3 individuals that were lost to follow-up actually achieve more than 50% pain relief, and that would be a worst case scenario for sensitivity and specificity. And you can see that in this case, the sensitivity dropped to 83 with the lower end of the confidence interval now down to 59. So it looks as though our findings, at least in terms of a relatively high sensitivity, were fairly robust to this scenario-based analysis, which was reassuring for us. And then maybe next slide, thank you. Just to say again, busy slide, but just the headlines. If you look at sensitivity and specificity, essentially the conclusions are the same, aren't they? We're continuing to see at 3 months much the same findings that we saw at 6 months. So last couple of slides from me. So again, I think I would just like to highlight one of the limitations of this study was that although we powered our study on the diagnostic accuracy of screening trials and indeed used our success rates were consistent with previous trials, so our percentage figures were fine. One of the problems that we had when we went to implement the study was the absolute number of failures in trial stim was relatively small. As I showed you, only 5. And we also had this problem that the loss to follow-up, 3 out of 5, was high. And I think we do need to take this into account in interpreting our results, which do compromise the certainty around our estimates of diagnostic accuracy. But that said, last slide, our conclusions were that SCS trial stim may have some diagnostic utility. And I guess if it is going to have diagnostic sensitivity, it appears to be a bit higher sensitivity. And we have an acronym in the diagnostic world called a SNOUT. So what's a SNOUT? So a SNOUT is a negative trial screen may predict out a low probability of having a future positive pain relief. So in other words, if you have a negative screen trial, that may be a good way of identifying the fact that you're unlikely to go on to benefit from spinal cord stim. Thanks very much.
Thank you very much, Rod. I think before we go on to listen to Rui, I think just a comment from me. The 3 patients who were lost to follow-up actually withdrew consent and left the study, and that's an inherent problem in that patients who have a failed trial, it's quite difficult to keep them in a study like this.
Thanks, Sam. Sam, as I think you know, I need to leave you this evening, so I don't know if there are any other key questions on the diagnostic side of things. I haven't seen anything. I guess I've just got the chat for the faculty. Have you got anything at your end?
No, I think you are free to go. There are no questions so far. If there are any, I'll direct them at you by text.
All right. Cheers, folks.
Thank you very much, Rod.
Bye.
Rui, the floor is yours with the health economic implications.
Can I just check that you can see my screen?
Yes, we can.
Yeah. Okay, great. So now I'm going to talk about the health economic implications of screening trials with a focus on results of the trial STEAM study. Okay, so for a bit of context, an economic evaluation can be described as a comparison between two different interventions in terms of their costs and their consequences. The purpose of an economic evaluation is to ensure that the maximum value for money can be obtained within limited resources that are available. So we consider the difference in cost of interventions and also difference in effectiveness. And then we get a figure that will let us know if an intervention provides higher effectiveness at a higher cost or at a lower cost. So it will fall within one of these quadrants. So ideally, we would want a new intervention to fall in this bottom right quadrant, which will mean that the intervention is dominant or it is more effective at a lesser cost. However, usually new interventions do present better effects, but at a higher cost. And when this is the case, we need to consider a threshold, which is a willingness to pay. So the maximum amount of money you'll be prepared to pay for a new intervention. So this line here represents the threshold at which point an intervention will stop being considered as cost effective. So in the UK, this is considered as 20 to 30,000 pounds per QALY gained. Okay, so recently we have completed a systematic review of economic evaluations of on cost effectiveness of spinal cord stimulation. These were the studies that we identified that looked at cost effectiveness of SCS in people with neuropathic pain. So the majority of these studies found SCS to be either cost saving or cost effective. There were only 2 studies identified that suggested that SCS was not cost effective. But the Allingworth 2011 study focused on a population of patients receiving workers' compensation, and the study by Slangen in 2017 was in a population of patients with painful diabetic neuropathy, but with a very short time horizon, only of 12 months. So it considered that SCS was not cost effective. Although it is widely recognized and most this does not mean that further savings cannot be made. And so this brings into the screening trials. A couple of years ago, Simon and Simon already mentioned this study, we looked to conduct a cost analysis of screening trials of SCS. For this, we consider only the costs associated with the screening trial, so only this part here. So in normal clinical practice, a patient has a screening trial. If it's successful, proceeds to a full implant, or if it fails, goes into usual care. The alternative that we're proposing was the patient going directly to a full implant. So we did not, we did not consider this part here. So the effects or the benefits that could be derived from the patients having a screening trial. So Simon mentioned the break-even point that we identified to be about 33% or implant trial rate of 67%. We also looked at previous RCTs and case series that reported this rate, and we observed that only the Kemmler study had trial to implant rate of 67%. So only this study will suggest that a screening trial will provide cost savings if used. Of course, and as mentioned, we've not considered potential benefits of a screening trial, such as identifying the patients that will obtain more response to this treatment. So this brings us into the trials team economic evaluation, where we consider not only the costs, but also the effects of a screening trial. So the aim of the economic evaluation was to determine whether a screening trial represents a cost-effective use of resources when compared to an implant-only strategy. The objectives were to present results as a cost-consequence analysis and also as a cost-utility analysis. So briefly, the methods that we used in the economic evaluation, we consider the perspective of the UK NHS and personal social services. The time horizon was that of the trial, so 6 months. Data was collected using case report forms at baseline, 3 and 6 months follow-up, and resource use was valued using UK national costs. The effects for the purpose of cost utility analysis were considered taking into account the health-related quality of life measured using the EQ5D5L. So this is a list of the resource use that was considered in the economic evaluation for both groups. So as already mentioned, 47 patients went through a screening trial, of which 42 proceeded to an implant and 5 failed screening trial, while in the other group, 49 patients went straight into a full implant. We also present here a list of visits to healthcare professionals that were pain-related and the adverse events that were also costed in the analysis. We also considered visits to healthcare professionals that were not pain-related and medication. So this was all costed, all medications, all treatments that the patients had during the 6 months period. So now in terms of the costs, so we can see that in the trial screen group, there were greater costs than in the no trial screen group. However, this difference was not statistically significant when adjusted for baseline EQ5D index score and also pre-specified stratification variables, including age as well, which was one of the questions before. In terms of the effects, we can see that patients that go through the screening trial obtain slightly more benefits than those that go straight to an implant. Although again, when we compare differences adjusted for baseline, EQ5D index score, and stratification variables, these results are not statistically significant. Okay, so what does this mean in terms of the cost effectiveness of a screening trial? So to evaluate whether we so incremental cost effectiveness ratio, and this is the difference in costs of interventions divided by the difference in the effectiveness obtained by both interventions. So as mentioned, screening trials, they have a higher cost, but they do provide some additional benefits. The ICER for a screening trial was found to be approximately 79,000 per additional quality gained. So much larger or much greater than the commonly accepted ICER of 20 to 30,000 pounds per quality gained. So this is another cost effectiveness plane, so similar to the one shown before. And this represents bootstrap estimates of different combinations to obtain probabilistic ICERs. So these are the result of 10,000 estimates. And as you can see, most of them fall on this top right quadrant, suggesting that screening trials provide more benefits at a higher cost. There are also some estimates that suggest that screening trials will produce less benefits at higher cost. When we consider the threshold commonly accepted in the UK of £20,000, we can see that most of these estimates are way above this threshold. If we look at £30,000, again, most of these estimates are above that threshold that is accepted in the UK. So here we can see the probability of a screening trial being considered cost effective at different willingness to pay thresholds. So if we consider the, again, commonly accepted thresholds in the UK, so at £20,000 per quality, probability of a screening trial being cost effective will be 9.2%, while at £30,000 will be 13.8%. So the probability of a screening trial being cost effective is very, very low at commonly accepted willingness to pay thresholds. We also conducted some scenario analysis where we changed the costs of implantation, the cost of screening failures, the cost of screening trials, and also where we changed the benefits obtained by undergoing a screening trial. As we can see here, when we change the costs of implantation, screening failure, or screening trials, there isn't much difference to the ICER. So all of them are still way above £60,000 per QALY. When we increase the benefits in screening trial arm by 10%, then the QALY decreases, or sorry, the ICER decreases to £31,000 per QALY, so much closer to the threshold. However, if we reduce the benefits obtained in screening trial arm by 10%, then a no screening trial strategy will become dominant, meaning it will be more effective at a lower cost. Okay, so I think it might have been mentioned already, the trial scheme was a pragmatic trial. So the eligibility criteria follows that of NICE, so we followed NICE recommendations in the UK. And one of the main considerations that there are regarding the results of trial scheme is whether or not the results are applicable to other settings, including the US, where implantation to trial rates as low as 41% have been reported. However, if we look at the trial success rates in recent RCTs, we can see that these are very similar to the ones observed in our trial and range between 86 to 93%. In my mind, I mean, I think this suggests that one of the reasons for difference in success rates between the US and the UK may be due to the selection process in clinical practice. So in conclusion of the economic evaluation, we consider that screening trial is not a cost-effective use of resources from a UK NHS perspective. The results may be generalizable to other settings, including the US, and no even wrong. Therefore, patient selection is paramount for SCS to be a cost-effective intervention. Now I'll hand over to Raymond, who will present on the qualitative results of trial scheme study.
I think before we go to Raymond, there are a couple of questions you might want to answer, Rui. Questions from Eric Buxer, which give you an opportunity to expand on the future work. Do you have any sense on how the results would be affected if the follow-up was 12 or 36 months or more?
Yes. So in terms of the 6 months results, we didn't see any difference, not only in terms of the health-related quality of life, but also there was no difference in pain intensity, disability, or any of the other outcome scores. So it shouldn't really affect the cost effectiveness of a screening trial, because if we included this data then afterwards in a model, it will be based on proportion of patients, so in proportion of responders. And because they are similar, screening trial, even if considered on a long-term time horizon, will not become cost effective. But I think in terms of the follow-up study, yes, we have recently obtained funding from NIHR as well to conduct a follow-up assessment where we'll check the pain intensity reported by patients as well as health-related quality of life, I think at 30 to 36 months.
You have another question from Ben Fear about the reduction in the NRS, and he's asking, the reduction of NRS here appears to be only in the order of 3 points on the NRS. Would that affect the NICE assessment of the spinal cord stimulation? I suppose they normally would look at the EQ5D.
Yeah, so in terms of, So if it's related with the economic evaluation in terms of cost effectiveness, so that will have to do with the proportion of patients achieving pain relief. And in this case, we're comparing, so it's basically, it's the same intervention, just a different strategy. So it wouldn't change, spinal cord stimulation will continue to be funded, but if anything, the consideration will be to remove the need of the screening trial.
Thank you very much, Rui. I think we'll now move on to the qualitative study, and if I would like, I'll share the screen with you and introduce Dr. Raymond Chadwick, who is our long collaborator and clinical psychologist at James Cook University Hospital, and he will present the qualitative study results.
Thank you very much, Sam. Can I just check that you can hear me okay?
Yes, we can.
Thank you very much. The aims of the qualitative study were very straightforward. We wanted to sample the expectations and experience of the participants in the main trial stim study. And specifically within that, to ascertain the preferences of the participants for a one-stage as against a two-stage procedure. If I could explain briefly, the language has changed slightly, and instead of, in our discussions with participants, instead of talking about trial and no trial, after careful thought, we decided that the simplest and most understandable terminology to use was for a one-stage procedure, in other words, proceeding direct to implant with no trial, as against a two-stage procedure when the participants would come in twice. So just to explain our use of terminology there. Thanks. Next slide, please. As was explained before, our method was to carry out telephone interviews using semi-structured interviews and sampling participants from all 3 trial sites. We aimed to interview 10 participants from each of the sites, giving us a total of 30 participants. And we aimed to balance the numbers, undergoing one-stage and two-stage procedures. We interviewed participants twice, initially when they had been randomized, but before they were notified which arm of the study they would be taking part in. Our intention there was not to influence the views of participants by the track which they were due to follow. And in fact, the interviewer was also blind at that stage. So although the centre was aware of the randomization, neither the participant nor the interviewer was aware. And then we interviewed again 1 month following the completion of the procedure. In other words, 1 month after the full implant had taken place. Just to be clear, we were asking, our questions were briefly about the pain that the participant was experiencing and the impact on their life. And we weren't asking which procedure would you prefer. We were asking them to reflect on the advantages and disadvantages of each of the 2 possibilities that were being offered. The interviews were audio taped. We carried out thematic analysis. And finally, at the end of the qualitative interview, we asked participants on a 5-point Likert scale what their preferences would be for a 1-stage or a 2-stage. So to clarify that, it was simply a 5-point scale. At one end would be a strong preference for a 1-stage procedure, and then passing through a mild preference, no preference either way, ultimately to a strong preference for a 2-stage procedure. Thanks. Next slide, please. The interviews we carried out, in fact, we over-recruited. We ended up with a total of 31 participants. That was simply because of in order to achieve a balanced recruitment between the two arms of the study, we ended up over-recruiting in one arm, and we decided that we would leave that participant in and have the advantage of their thoughts anyway. And the analysis of the results from the pre-implant interviews gave us two broad themes. One was related to the expectations of spinal cord stimulation, and the other relating to their preferences between the two options. The expectations, I think, were not surprising and reflect very much the previous literature on this, that they were hoping for pain reduction, for an improved quality of life, an improvement in sleep, and an increased range of daily activities. In terms of the preferences between 1 or 2 stage procedures, there were 3 broad subthemes. One was the time requirements for the 2 stage, with a distinct advantage being seen that the 1 stage procedure would involve less of their time. The practicalities also pointed in the direction of a 1 stage procedure, and for many participants there was a concern about having wires hanging out during the period when the trial was underway. And then perhaps an unexpected theme emerged, which was that there was a considerable awareness of the importance of saving NHS resources. I guess there's a lot of awareness in the media at the moment about pressures on the NHS, and perhaps that's a reflection of that. Next slide, please. Now, what I'd like to do is just to give you a flavour of some of the transcripts that we analysed. I'll give you an opportunity just to read through those quotations yourselves. So I'm sure you can see there are a range of themes coming through. The first one is just a broad statement of principle that a single stage thing is simpler than a 2 stage. With the second quotation, it's a matter of time, particularly relating to work and saving time. And the benefits for the participant of having only 1 procedure. And the third is an awareness that some participants showed of needing support of families and imposing on them twice rather than a single time to get them to the necessary appointments. Thanks. Next slide, please. A couple more quotations. And so just again, giving you the flavour, the first shows the kind of anxiety that participants were reporting about the concern of having loose wires during a trial period, and also a reflection on the resources, the greater drain on NHS resources. Thanks. So with the next slide, please, we'll turn to the results from the interviews following implant. You'll notice there that disappointingly, we lost a number of participants to follow-up. The principles that we followed were to, although obviously we'd taken consent from all participants to be contacted at the follow-up period as well, we did have difficulty contacting people by telephone for the follow-up interviews. And the strategy that we adopted was to try to contact them 3 times. And at that stage, simply left a message saying that unless we heard from them, we decided that they were no longer able to take part in the study. The themes that emerged from the second interviews followed, first of all, the main outcomes from spinal cord stimulation. And these, in fact, largely mapped onto the expectations of participants from the initial interviews. So the pain relief and improvement in function were very clear from the themes. But there was one additional theme, and we suspect that this may be a novel finding as far as the literature is concerned about participants undergoing spinal cord stimulation. And this was the satisfaction that they gained, not only from their own subjective experience of improvement in functional abilities, but also feedback from family members, from relatives who observed that they were more cheerful or more able to participate in family life, which gave a great deal of satisfaction and was a good change to see from their point of view. The second theme was about the practical issues of living with spinal cord stimulation. Obviously, at the outset, they had only the advice to go on from clinicians or perhaps from expert patients that they'd been able to speak to. But the direct experience of living with a stimulator increased their awareness of issues about the importance of changing settings. Sometimes it was helpful for participants to feel that they had the freedom to change settings, but then sometimes it was a frustration that this could only be managed by a return to a clinic appointment. Also, the practicalities of recharging batteries, which some of them felt had taken them unawares. And as soon as they had the implant, this was something which affected their daily life quite a lot if they had a rechargeable device. The third main theme was about the value of information which had been provided before the procedure, and considerable appreciation was expressed for the information that they received from their treating clinician, also from the internet research that they'd carried out, but particularly from expert patients that they'd been able to talk to, which they found extremely helpful. The next theme was about the management of expectations. And whereas from the initial interviews, perhaps participants had a general idea of having less pain and being able to do more, they were now in a position to make much more specific judgments about what it could and couldn't do, that they weren't pain-free, but they were able to extend their activities in certain ways. There was still a certain amount of pain to manage and fatigue to manage, but there was a recognition that it was important not to have expectations set too high and to be realistic in what was achievable. Came out much more clearly from the second interviews. And then finally, the theme was about their preferences between the 1 and the 2-stage procedures and the reflections on that. The next slide, please. Some quotations just to illustrate the reactions. The red text at the afternoon of each just simply identifies which arm of the procedure the participant took part in. So those quotations just illustrate the attractions of a single stage procedure to these two participants. One showing an awareness of increased infection from additional procedures being carried out. And second one, the time involvement and also the costs at a personal stage if they require accommodation to attend. Next slide, please. A couple more quotations. I think the first quotation there illustrating the, in practice, the actual risks of having something outside the body during the trial period. And And the second quotation does illustrate quite a recurrent theme from our transcripts, that some of the participants felt a little taken aback at the pain and the extent of recovery that was required from both procedures, as if they hadn't quite been expecting that. Next slide, please. So the results overall from both interviews indicate that there's a very clear preference for a single stage procedure. The reasons for the preference are grouped around quite clear themes. First of all, a single stage involves less time off work, in hospital, traveling, or with use of requirement for childcare. Only a single surgery, so only a single period for healing and recovery. The discomfort and worry of loose wires was avoided. If you remember, we were asking participants to reflect on the advantages and disadvantages of the two options that they were faced with. Really, the only reason that the interviews produced in favour of having a trial period was that in the event of it being unsuccessful, it would be easier to remove. But that was pretty much the only advantage that was spotted in having a two-stage procedure. Next slide, please. So finally, moving on to the ratings, which we asked participants to complete, both before and after the implant. Just to explain the slide briefly, the 5 points of the scale are in the first column down the left-hand side of the slide, from strongly prefer a two-stage procedure through no preference to a strongly prefer a single-stage procedure. Then in the first column, the number of participant responses against each of those 5 options. The colours indicate the red colour simply indicates those who are randomised to a two-stage procedure, and the blue to a single stage. And the final column indicates the responses from the follow-up interviews. The arrows in between simply indicate the direction of change of opinion. And from that slide, I would really just draw your attention to 2 facts. One is the overwhelming preference, strong preference for a single stage procedure. Between the 2 interviews, 4 participants changed their opinion to favour a one-stage procedure, and only 2 participants changed their opinion against that overwhelming impression. Next slide, please. So, in conclusion, the results of the qualitative study add further support to the result of the... oh, have I missed a slide somewhere there, possibly, Sam? Yes, yeah, thank you. Sorry. Overall, then, there was a clear patient preference for a single-stage implant procedure with no trial period. It was also clear that the information needs of patients remain a high priority, including access to expert patients. There was also evidence that preparation is of considerable benefit to participants to explain fully not only the procedures but also the recovery, and to assist in their subsequent adjustment to living with a stimulator, and that appropriate support through preparation and follow-up optimizes the benefits of the procedure. Final slide, please. So in conclusion, there is overall further support for the results of the trial STIM study. And in addition to the evidence that screening trials don't add to patient benefit and do not add value for money, there is strong patient preference not to have a screening trial before the implant. Thank you.
Thank you very much, Raymond. It's very interesting to see the patient's views align with the RCT results. If we may ask the attendees, if you have any questions, please type them in the Q&A panel, for Raymond, and if we have any after the presentations, you'll be able to ask questions by raising your hand when we're finished. So if I may take you into the summary and conclusions from the trial STIM study, now we have seen the results. Basically, I would like to just take a moment to look at the study strength and limitations. This is one of the few studies in spinal cord stimulation that's independently funded and conducted. So there was very little intervention from industry here. Again, it is a very pragmatic study. We aimed to look at the practice of SCS in the UK and conduct our trial within the practice without altering the practice, and I'll come back to that in a minute. Again, this is one of the very few studies that looks at spinal cord stimulation as a generic intervention, not a device-specific intervention. We have a lot of studies that compare device A to device B, but we don't have a lot of studies that look at the spinal cord stimulation generically. The devices in this study were programmed by the neuromodulation nurses in the 3 centers with some assistance from industry only when needed. I looked at this and found that there were only 2 programming sessions that were conducted outside the follow-up times for the study. The follow-up times with the study aligned with our clinical reviews, 1, 3, and 6 months, and there were only 2 patients who requested programmings outside this. The results, as you've seen, are consistent between 3 and 6 months and very robust to various sensitivity analysis. We couldn't find a difference. As Ash told you, there was no difference in the analgesic intake, and we purposefully did ask patient to did not interfere with patients' analgesia unless patients came to us and asked for a reduction in medication. The observers who took the pain scores, the EQ5D and ODI, were blinded to which group the patients were in, and the information sheet was composed to give people equipoise about which of the 2 strategies was better. Now, if we were to look at the limitations, ours is a small study. When you think about it, we recruited 105 patients, but in terms of spinal cord stimulation, this is the same numbers as the PROCESS study or the Sunburst study. So yes, it is a small study, but it is reasonably sizable compared to in the spinal cord stimulation field. The investigators and the patients were unblinded, and of course that was quite impossible to blind those to the type of trial. The follow-up, we acknowledge that 6 months follow-up is a short period. However, we were not assessing the outcomes of spinal cord stimulation itself, but the outcomes from the trial. So we would argue that if you're assessing the outcomes from the trial, a 6 months follow-up is probably reasonable. And although our screening trial success rate are very consistent with previous trials, as Rod told you, the absolute number of failures was small, and that compromised our power to study the diagnostic utility of the trial, but not the patient benefit. Finally, our cannot account for false negatives. The patients that Simon talked about in the Oakley study, those who have a trial turn a negative result but would have done better if implanted with spinal cord stimulator, no healthcare system allows you to implant those. So if I may compare our responder rate, we as implanters are very highly trained to look at the percentage and the responder rates. If I were to compare our responder rates to other studies in spinal cord stimulation, you will find that our responder rates are below other studies. You can see that our responder rates are about 40%. The responder rate from PROCESS was 48%, SENSA 75 and 37. So we're approaching the paresthesia arm of the SENSA study. These are the overall responder rates, not just the back or the leg. And we're nowhere near the responder rates of the overall for the EVOKE study. Now, you may ask yourself the question, well, why is that? Well, there are, I suppose, many factors that contribute to this. First of all, we're not offering patients anything that is novel. We're not offering anything that is outside the treatment that they would have received in the NHS. These patients were implanted as routine clinical practice. It's a treatment they would have got anyway. So that's an issue. The other issue is about the selection criteria of the study. And if I might remind you of what Barani told you earlier on, this was intentionally a pragmatic study. So we chose our inclusion criteria to mirror exactly the NICE guidance criteria. So these first 3 or 4 statements exactly are copy-pasted from NICE guidance for SCS. And that is intentional because we wanted to study the impact of no trial on patients who would receive an SCS in UK practice. Therefore, that produces, of course, a heterogeneous group because you are not specifying exactly a single group of patients as studies like SENSA or EVO would have done. And that, to my mind, gives you the true impact of spinal cord stimulation in clinical practice. So what about the different systems? As Ash told you, the systems were left to centers to choose which device they wanted to implant in the patients. We didn't interfere with the choice of the centers. And we used devices from 4 major manufacturers in the study. They were programmed, as you were told, paresthesia, 10 kilohertz, and burst stimulation. Did we observe a lot of difference between these patients? And the next slide, before I show you that, you have to remember that we weren't powered to detect a statistically significant difference between these 3 modes of stimulation. However, the clinical results, if you can see the mean pain scores before and after for the 3 modes of stimulation, you can see for yourself that there is no great clinically significant difference between these modes, which came as a surprise to us. So finally, to conclude, the spinal cord stimulation trial screen may have some diagnostic utility. However, there was no patient outcome benefit of having a trial. That we can tell you for sure. The participants overwhelmingly preferred an SCS screening trial, and it's not only in interviews. We could see that in at the randomization stage. Finally, as Rui told you, screening trials are not cost-effective from an NHS perspective, and this study perhaps uniquely portrays the impact of spinal cord stimulation as an intervention generically in UK clinical practice. What our next steps are to look at the uptake of SCS across NHS England in England, as Rui told you, and then assess the budgetary and health impact of the NHS removing the SCS screening trial. And we have a funding for a 36 months follow-up from the NIHR policy research program. And now if you, I'll finish here and I'll say thank you to our patients, the patients advisors who worked with us on the study, Mrs. Jenny Earle and Jill Bell, both spent quite a lot of time. Our principal investigators at 3 sites we've heard from, Morag Brooks, who's with us on the call, our study manager, and Shelley Rhodes, the study manager at Exeter CTU, the study nurses. The trial steering committee were Richard North and Alan Batram, and our qualitative study team, Raymond Harbinder and Rebecca McNaughton, who I'm very pleased to have found photographs of on the internet. And finally, our thanks to our funder, the National Institute of Health Research.